First,
Yeah, that's why I must work like this. Sorry, I don't know. Some of my students try to show me how we can change that, but Zoom have a new version, and that's why redact these functions. Okay, I think that today we speak 40 minutes, not more, because I feel myself not so well. That's why it's so difficult to me to speak more. Are you agree with me? I think that yes. My students, yes. Okay. Today we speak about the polytrauma, combined trauma, and multiple trauma. If we speak, first of all, let's start to speak our lovely information. It's a statistics things.
É só pra. Vai que o meu fone tá aberto ali no vídeo, né? Eu não sei.
I don't understand anything if you want to tell me something. Thank you so much. It's a some entrance to our chat. If you speak about the what is it? If you speak about the statistics things, you check this. First of all, polytrauma happened in the young, more younger age group. It's 18 to 45 years old. Why? I think that you must understand the polytrauma. It's a high energy trauma and who live fast. Just younger persons. Maybe in other countries, the pensioners can travel and something else, but in Russia, the most faster live who more younger persons, and that's why the high energy trauma happened with these categories of people more often. It's the third most common cause of the death in all age groups. It's a high energy trauma. That's why we have too much of different injuries, combination of deaths, and that's why polytrauma. If you speak about the non-multiple fractures, the cause of this, and maybe our treatment case is not finished by this. In a polytrauma, yeah, great economic and social loss to country, too much of invalid persons, too much of persons who lose your work possibility, and that's why it's a great economical problem too. And you check our days with the great economical problems in each countries in the world, depend by the SARS-CoV-2 infection and something else, and polytrauma take too much of money, and sometimes maybe patients with the polytrauma take the money from the COVID patients. The definitions. This topic I start with my students in the lessons about the definitions of polytrauma, multiple trauma, and combined trauma. And sometimes the students tell me that too much of fractures. Too much of fractures, it's a polytrauma in a different localization. No, for example, if you speak about the fracture of femur, for example, and the forearm, it's just multiple fractures, it's not a polytrauma. Because polytrauma must change something in the homeostasis of our patient's body. And in these slides, you have two definitions of these injuries, and all of them describe as the general changes in the patient's bodies, depending by the different localization of the fracture and depending different stages of them. Are you hear me well? I don't speak so quiet.
it's good.
Abhishek, you give me the opinions of all of my questions. I prove you. Why? Because you know what is the best football club in the world. Where is my PSG lovers? Polytrauma and multiple fractures. It's not a symptom. I told you that's not a symptom of multiple fractures. We must have different kinds of injuries and some disturbs in internal organs too. Multiple fracture, it's just our problem, traumatologist problems. And if you speak about the polytrauma, we must work in a group, and I told you about this after a few slides, which doctors must include in this group for decide all problems with the health for the patient with the polytrauma. Господи, как же тяжело. You see that the polytrauma is multi-system injury, and they need the management by surgeons, physiatric, sometimes neurosurgeons, sometimes thoracic surgeons, urologists, cardiovascular surgeons. That's why if the patient admitted in each hospitals with the polytrauma, or maybe if we speak about the about the ways of transporting this patient, you must choose the multifunctional hospital where we have too much of different services, where we have too much of different investigations and different kinds of doctors. For example, if the patient with the polytrauma admitted with a small village hospital, the chances for the Hello Peter is too much for this patient. If maybe, for example, like in Областная, if you speak about the about the Kursk city. If you speak about the mortality isolated trauma, it's near than 2% just. Multiple trauma 10. And if you speak about the mixed or combined trauma, you see that near than 33% of these patients are dying, and these deaths happened in the first days after admitted, because this heart disturbing the homeostasis guaranteed these high numbers. If you check, it's an interesting picture which describe as the most lovely localization in the persons. If you speak about the polytrauma, you check that usually we have which according. It's some skeletal trauma with the near than 80% of injuries, or maybe different disturbance in the skull, in the brain. So the 14% we speak about some problems in the chest cavity. The same percent if you speak about abdominal, pelvis, usually broke not so oftenly, but all of these regions, according of these regions, guaranteed that our patient have a hard and difficult generally status. Classification. If we want to classify them, we must do like this. Isolated trauma, it's a trauma of one segment. Multiple trauma, it's two or more segments and two or more internal organs. And combined trauma, internal organs and two or more internal organs, more than one, or into one cavity. Sometimes in a different stages and in different books, in Russia, for example, we understand combined trauma from the different term. Combined trauma, it's a different nature of traumatic causes. What is it? For example, it's a multiple fractures, and maybe two or more segments, and injuries of any internal organs, and some other things like burns, like frostbites, like some ionic burns, and some others. But I think this depended happening historically. In our country, we have too much of post-war patients, and we classify them like a combined injuries. In the international literature, combined trauma seen like on my slide. Stages of polytrauma with combined. First of all, it's a moderate. It's a shock or contusion of the head, isolated. You can check here the different combinations which product us then combined injuries. High, it's a first of all shock, first or second degree, and critical, very bad condition. And that's so interesting words. Patient may die. Patient may die anywhere, any day, and any second, without depending of anything. But you see the criteria. It's a different wounds, it's a different localizations, it's a different different kinds of losing of blood or losing of volume generally, and stages of polytrauma happening and after 1 second after accident. If you have a patient with the different localizations of the fractures, you must understand how much of blood your patient can lose. For example, if you speak about the isolated fractures of the pelvis, the patient can lose 1/2 or 1 liter. If we have a unstable fractures of pelvis. It's a vertical and horizontal kinds of them, and we have an injury of any intrapelvic organs 3 to 3.5 liters. In the pelvic, in the abdominal cavity, dependent by the rupture of any cavity organs, for example, cavity and parenchymal organs, we can check that our patient lose near than 1 or 2 liters. In a chest, the volume of our peritoneum cavity, we have 2 of them. That's why all of them can include 1 liter and 1/2. In a skull cavity, 1 liter. That's why if we check a present in blood in any of these cavities, we have not any free blood into the vessels. But this this combined kind of losing of blood usually finished by emergency dive. But if you check on the X-rays and try to summon the volume of the losing of blood, you can check and you can use this picture for summing all of them and make the decision about the general condition of your patient. There I told you about the cavities. Here we speak about the fractures. All of you know that in our lessons we speak about the femur, like a shockogenic zone. If the patient have a fracture in the mid-shaft of femur, patient immediately lose near than 1 liter or maybe 1 liter and 1/2 of blood. Here on this picture, we try to show you. I can translate this picture in English because we have the any rights, but femur 1 liter and 1/2. Tibia near than 1.75. If we speak about the upper extremities, the size of these bones not so big. That's why near than 1 liter. That's why, for example, our patient have multiple fracture femur, humerus bone, and maybe mid-shaft of forearm. Let's summon near than 3 liters our patient lose. It's an acute losing of blood. It's a 3rd degree of shock. Here in the place of accident. And this is so dangerous, the condition for our patient. First speak of that. I don't know, maybe on this picture you see the last model of ladder, but I don't think so. But why the patients died in emergency? It's a severe head injury, brainstem, high cord injury, head, aorta, and massive blood loss. I don't think so, and I told my students today, if you want to choose the car and you have you have this, you must make this choice. Let's choose the Volvo. The most safety cars in the world. I understand that you see it so cool in the last model of Land Cruiser, but the Volvo, I think so, can save your life. Second pick of that, it's an intracranial bleed, chest injury, abdominal bleeding, pelvic bleeding, and multiple limb. And here, if the patient stay alive after first peak of that, here we have a low like a golden hour. If we understand the target of bleeding, if we can start to compare this losing of blood, if we stabilize all of these injuries, and if the patient stay alive into this golden hour, we can guarantee that maybe we have well chances for well results in the future. And we must make all our investigations and all our stabilization steps into this gold hour. And this is theory. First of all, I want to tell you like this. In a polytrauma treatment, we have some philosophy, and I told too much of you that we have some principles how to treat, and I think that all of these principles based on some experience and some knowledge. We have a statistics, results. The Russia winter want to kill us. We have so poetic maybe names like a golden hour, like a platinum 10 minutes and others. But all of these things based on too much of information about these patients, about the needed, and about all. I can give you commentaries for all of my slides, but the third peak of that, it's a several days a week. Why? After too much of open injuries, after super infection of these wounds, we can start to see what? We can start to see the general purulent problems. We named it like sepsis, and we speak about it, and organ failure. If the patient lose too much of blood, we try to compensate it, but if we have acute organ failures, that's why in the first several days or weeks, our patient can have a third peak of that. Lifestyle age. Too much of patients are dying in emergency cars, and the patients can transport in the life conditions to the hospitals. 30% of patients died within the first 4 hours after reaching the hospitals. 20% of patients in the next 3 weeks in the hospital. That's why 17% of death can be prevented. Non-salvage is dead. Somebody go out. It's not so interesting. Sorry. Aims and management. First of all, if we speak about the having following priorities, we must guarantee life salvage, limb salvage, and salvage of total functions as possible. It's a general terms, and all of these terms based by too much on investigations and too much of other things. Criteria of traumatic shock. First of all, we have a criteria, and I show you this here. Stages of shock according by the systolic pressure. Its first degree of shock, it's higher than 19, second 19 to 17, third 17 to 15, and 4 lower than 15. In different books and in different stages, you can find the different numbers of this. And I told you every my lecture, if you want to find something new, let's change the numbers just and tell that you are author of this. But for example, 92, it's a first degree, maybe, but we told that more than higher than 19. Sometimes all of these numbers is not the first hour base when we try to classify the patient's shock, but you must base on this on these levels of the blood pressure. Shock, it's defined as it's a decreasing of perfusion and oxygenation of tissue. The causes of the shock generally, and we can classify all shocks depending by the pain, bleeding, trauma, and stress. If we speak about the traumatic shock, our traumatic shock, it's a combined form. First of all, I told you that it's so painful for our patient, and if today we speak about the multiple injuries, that's why it's a so high pain efferent signals to the central brain. And secondary, you have a previously slides when I show you how much of bleed or how much of blood our patient can lose. That's why let's compose these two conditions and understand what does it mean traumatic shock, and why we have a losing of or decreasing of the blood pressure, and why we have all of these changes. That's why risk factors for the traumatic shock. How much of us present here? Clinical finding, hematologist finding, coagulation, and blood loss. First of all, clinical finding, it's your pulse, it's your beat rate, it's a level of the blood pressure, it's a level of hematocritus. Hematologist, hemoglobin. Normally, you know the normally size, normally numbers of this. If the hemoglobin lower than 18 to 100, hematocritus 35, 38 to 32, and we check some problems with the fibrinogen and other coagulation factors, that's why it's a first degree of shock. According blood pressure levels and a red blood analysis, and how much of blood our patient lose. Else, second and third degree. Because if you just check the decreasing of hemoglobin lower than 17 here, and the patient have a normally beat rate and normally blood pressure, it doesn't mean that our patient have an anemia. Our patient have not any shock. That's why, and if the patient non lose the 30 or 14% of her blood, or maybe 1 liter and 1/2 and 2 liters. That's why let's check, let's get the full information about your patient. Characteristics of polytrauma. Can I get commentary? This is not so interesting. Principles. This is more interesting situation. If we speak about the polytrauma treatment, we must use some special philosophy, which based on these three principles: principle of domination, principle of combination, and principle of single trauma. Of domination, any critical situation and so should act very fast up to processing to the next stage of treatment. You must choose which of these injuries dominate in this clinical picture. For example, femur and rupture of spleen. Rupture of femur, you can stabilize this by special transport casts or fixate by skeleton fracture in the hospital, and like this you stop the bleeding. If you have a rupture of spleen, you have intra-abdominal unstoppable bleeding, and this rupture can kill your patient. Which of these two injuries dominate? Abdominal trauma. That's why which of doctors play a main role? Surgeon, abdominal surgeon, and trauma and traumatologist. It's just second. Play here just a second role. Triage. Triage sieve to separate death and the broken from injuries. Triage sort. If you have too much of patients which admitted to your hospital, you must understand which of them need a emergency present in an intense department, or maybe some of them can present in the general conditions. That's why triangle sort, it's a categories of peoples. First of all, first category, it's a critical and cannot wait. You must maybe emergency operate them, or maybe you must intubate and start to intensive therapy. Second category, it's organs, can wait 1/2 hour or maybe more. Category 3, it's less serious injuries, and category 4, expectant. All of this patient must be hospitalized, but this patient don't need any acute surgical treatment, and maybe you can wait sometimes for investigate them more deeper and change something into your treatment tactics. How to triage? You must answer on three questions. First of all, can the patient walk? Yes or not? Check for breathing. Is the patient breathing? No. Open the airwaves. Are they breathing now? No. Your patient died. Sorry. If yes, immediately help. If the patient have a so fast breathe more than 30 minutes, check a circulation. And if you want to check a circulation, capillary refill 2 seconds immediately, capillary refill no more than 2 seconds, urgent. I take this classification and I find him just in a unknowledge word, for unknowledge language for me. But I think that our Portugal speaking students can translate this and describe the Triage of Manchester. It's a I'm sorry, but I think that I stay sick. That's why we made this short lesson. Glasgow Coma score. You must understand that which problems of the of the head trauma your patient have. That's why here you can use the Glasgow Coma International Classification, and you can check and you can summon the final bells and understand in which degree of coma your patient have and how it's now so risky for your patient for maybe made some for made some emergency surgical needed. Medical team. I told you that not all over. Maybe if you work in a small hospital, you like a surgeon there and the patient admits with the polytrauma to you, you must play all of these roles. But main role here play who? Anesthesiologist, reanimatologist. Why? Because they must stabilize the patient's general condition. They must guarantee that the patient can breathe, inspire and expire, maybe by the intubation tube, maybe by the connection for breathe apparatus and some others. That's why in the first hours, 4 hours when the patient admitted to the hospital, the main role play these these doctors. Next, from other speciologists, and this role depends by the domination principle, which of injury dominate on others. But you check that here we have a general surgeon. Why? If we have some intra-abdominal problems, and maybe we must make the emergency laparotomy for check the target of the bleeding. Traumatologist for stabilize the skeleton problems, for maybe stabilize the fractures, use any external fixation apparatus and others. Neurosurgeon, don't forget about the 78 persons in a combination of the multiple trauma. And if the patient have maybe high bells on the Glasgow Coma score, the neurosurgeon must help you for decide these problems with some hematomas and others. Thoracic surgeon, if our patient have a multiple ribs fracture, if our patient have some intra-chest bleedings, and now if our patient have a tension kinds of pneumothorax, we need a thoracic surgeon. Maxillofacial surgeons, you check return. If the neurosurgeons work with the skull cavity, facial surgeons work with the facial part of the skull and stabilize maybe the mandibular and others. Urologist, when we have a topic about pelvic injuries, we speak about the rupture of bladder, and we can check the shaking of kidneys, for example. That's why if we have a rupture of all of these organs, our patient have a great problem, because after a few days the urine peritonitis starts, and then our patient have a great purulent problems. That's why we need all of these kinds of doctors in our hospital. That's why you check this list, you check this team, and you understand that it's a well level of the hospital who can help this multiple trauma patients, and just combinations of these doctors can work in our golden hour, platinum 10 minutes, and others. And that's why this combination minimizes the number of the death of after multiple traumas. First, diagnostic plan. You must understand, and this plan based on a domination principle too. First of all, you must correct the airway with stabilization the cervical region. Any critical needed. Check the breathing, check the bleeding and stop this bleeding, check for damage of central nervous systems, and full checkup. That's why you have some checkpoints when the patient admitted to your department. You must make the general and first general examination for find maybe any open targets of bleedings. You must check the beat rate, you must check the blood pressure, you must check the number of bit rate and others. And after that, you made the full checkup and decide which which categories of people, depending by the triage, you must use. Here I show you the picture of correction of airways with stabilizer cervical organs. You must use the so soft plans. You don't want to turn the patient before any investigation, turn her cervix and some others for guarantee that your patient can step breathe. Breathing function in heavy trauma. We must guarantee that our patients can breathe. And you must make this. I told you to my students how you can save the patient's life by the pen. If the patient have both kinds of pneumothorax, here you need a consultant of otorhinolaryngologist for if you can intubate your patient, you must do that to maybe puncture, conicotomy, tracheostomy, you need a consultant and other doctors, and cricoterotomy for guarantee that your patient not lose her breathing function. Else, emergency for the adequate breathing. Intercostal drain, you must do that on a local anesthesia. You must insert. Sometimes you can touch it by your palms, and you inject there and insert the tube for reduct any tension kind of pneumothorax. Sometimes you must do that before any investigation. If you find that your patient has a subcutaneous emphysema, it's a great criteria for presenting of tension pneumothorax. That's why maybe sometimes you have not any time for transport your patient to special X-ray cabinets, and you do the thoracentesis before anything. Breathing function. That's why which kinds of chest injuries you must correct immediately. Tension pneumothorax, I told you about this few minutes ago. Massive pneumothorax, you must don't forget that where you made the thoracentesis. If the air, you must do that in the second intra-rib space in the mid-clavicular line. If you speak about the pneumothorax, it's a 6 or 7 intra-rib space in the mid-axillary line. Unstable thoracic cavity. It's when we have window kinds of the ribs fractures and we have a paradoxal breathing. That's where you must stabilize the chest by any external fixation systems. Open thoracic trauma and damage of tracheobronchial branch. The last two cases must consult by the thoracic surgeons because they must put the adequate stitch and they must stabilize the chest by her special methods. SS of airway. Interesting. I have a positive or negative PCR test now. Maybe it's Omicron. Nobody can now want to answer me. Things of our way obstruction. You can look this, you can listen, you can feel. Which things you can look? Agitation, poor air move, rib retraction, deformity, and foreign materials. Listen. You can ask your patient, you can hear the noise of breathing, you can hear the stridor if you have any restriction of the bronchial branches, and you can feel the crepitus of the ribs fractures, you can feel the tracheal deviation, hematoma, and you can see that the patient can face. Can you read it? And I don't give a commentary. Sorry. How much we do it? 14 minutes. About one I want to tell you else. It's an airway, I told you. Yeah, more on this. I want to commentary this. If you speak about laboratory diagnosis and some investigations in a time of accidents, you have not any hypertension, you have not any redness and something else. For you, it's nothing. The temperature, the general temperature of our patients, usually it's normally. ECG, very slight chances. Pulse, usually more higher than 90. Why? Because our patient lose too much of fluid and we have a high bit rate. X-ray. You must make the X-ray of all interested for you areas. And which problems here? You don't forget that you can't turn your patients. That's why sometimes you can check just one projection of your needed segment. But, and which diagnostic problems you have? If your patient has some pneumothorax and some others, we don't forget that we must make these X-rays just in a standing position for check the level of or layer of the fluid. In this situation, we can't do that. That's why we can see some problems and we can make some diagnostic problems. Hemoglobin usually more lower than 18. Leukocytes normally. Why? Because in an admitted time, our patient have not any purulent problem or maybe septic problems. These things can happen after in the first 1 week after injury. And if we speak about the diuresis, we can check that the kidneys work more faster. That's why we have a 14 milliliters per hour. Why? Because we have decentralization of all fluid in the patient's body, and that's why we can see the activation of kidneys. But after a few days, these activations change her role in kidneys failure, maybe acute, maybe chronic. But these things here, laboratory diagnosis, our patient usually, if the patient lose the blood, that's why the patient lose the total protein. And if you speak about the different types of this protein, albumin, it's 2, pH changing in a more acidosis. And if you speak about the saturation usually decrease, but dependent by the NHS trauma. And all of these criteria can base for you the general condition of your patient. Tactical groups. So let's do this. So tired. Osteosynthesis. I want to describe you this. In a first week of admission, if our patient need a big and so long operations, we don't use that. Why? Because all of these things can guarantee that the general condition of our patient stays so bad. More better if we use the intramedullary kinds of fixation. Why? Because we made so small approaches into this situation that our patient don't lose too much of blood and we don't change her general condition. And the most often and most interesting for us that we can do this operation early. For example, mid shaft of femur, two transverse fracture, two different operation, open approach and using by plan and screws, and the approach needed 20 centimeters. That's why intra-operation losing of blood needed 1 liter another. Or intermedullary kneeling with the intra-operation losing of blood 100 and 1/2. Which tactics you use? Late operation with a high intra-operation losing of blood, or early operation with not so much of losing of blood and early activation of your patient. That's why you must use the first type. But don't forget that all of us in the adult age, we have a fat into our bony canals. And if you use all of these intermedullary constructions, you can see the fat embolism of the brain arteries. That's why we can see some small micro insults into the brain. That's why this may be gold time for our skeleton operations happening just after 1 or 2 weeks after operation, after general stabilization of our patient. First actions for therapy of traumatic shock. Liquidation of pain. How we can do that? We must immobilize these extremities. We must block maybe made the local anesthesia of these fractures. And we can use the narcotic drugs. Restoration of gas exchange and restoration of blood circulation. All of these 3 steps can change the stage of shock to a more lightly form. Normalization quality of blood, normalization of peripheral blood, and restoration of gas. You must use more than 2 or 3 veins. Why? Because the speed of your infusion, it's near than 25 milliliters per minute. That's why usually if you can't punctate the subclavian vein, you can use the veins onto your patient's arms and some vein in the lower extremity. But the anesthesiologist in her departments can insert the catheter in a subclavian vein and guarantee that you can make this fast intravenous injections. Program of infusion. I told you like this. I show you this slide, but it's a historical slide. When some years ago, when the traumatologist treat the patients with the polytrauma, we choose, then we decide how much of any kinds of infusion we must make it. Nowadays, it's just anesthesiologist work, and they know more deeper than our. But we have a rules. If the patient lose, I don't know, 1 liter, how much of crystalloid solutions we must inject? Twice than our patient lose. How much of colloid solution? 1/2 than our patient lose. Immunopharmacotherapy, immunocorrection after grafting blood cells is not so interesting for us. Group, sorry. It's so difficult for me to commentary on this. If you need this full kind of this version of this lecture, I can send you in a WhatsApp or somewhere else. You understand me? 14 minutes, like I told you.
Yes,
Yes, doctor.
that's fine.
Happy New Year, students. Stay healthy and see and feel you so lucky in the next year.
But
I think that the next year must be more better than this.
New Year, sir.
so,
And
you
happy
too.
Christmas.
New Year.
Year, sir.
Thank you.